Welcome to Grand Rounds for Rehabilitation and Movement Sciences for August of 2026. Please make sure that you sign in either using the QR code on the right side of the screen or the activity code on the left side of your screen in whatever method. And make sure at the end of the presentation, complete both the evaluation and the course quiz to get the appropriate CME or CE credit. And as always, if you have any questions, please reach out. So today we have Dr. Hilderbrandt, Dr. Brittany Hilderbrandt talking to us. Dr. Hildebrand graduated from Bloomsburg University with a Bachelor of Science degree in biology and a Doctor of Audiology degree also from Bloomsburg University. She is certified and licensed as an audiologist in the state of Pennsylvania, and she offers experiences in comprehensive audiometric testing for all ages, auditory brainstem response testing, balance testing, and hearing aid treatment options. Her philosophy is a clinical approach to hearing healthcare that is based on research and centers on assisting the individual needs of patients. In her spare time, she enjoys being outdoors and hiking with her 2 dogs and owns a local CrossFit gym with her husband. So this is our designation statement, and the planners and presenters have nothing to disclose. And these are our learning objectives. So without further ado, I will turn this over to Dr. Hildebrand.
Hello, good morning, good afternoon, I guess. Again, my name is Brittany Hildebrand. I am a clinical audiologist and the clinical coordinator of audiology. I work out of our Bethlehem location. St. Luke's Audiology does have 3 locations, one in Bethlehem, Tamaqua, and Phillipsburg, New Jersey. I'm here today to talk to you guys about hearing loss, the long-term effects of hearing loss when untreated, and the need for timely and appropriate referrals when working with patients that are, again, hard of hearing and potentially starting to see those cognitive declines. So just a general overview of the audiology scope of practice. So at St. Luke's, we do not provide the last 2 boxes, the facial nerve monitoring or the intraoperative monitoring. However, they are part of the general audiology scope of practice. At St. Luke's, we do provide diagnostic hearing tests for infants all the way up to adults. We provide correction and rehabilitation for hearing loss, which would include hearing aids, assistive listening devices, and potentially some oral rehabilitation. We also provide vestibular assessments, VNG testing, and some of our electrophys testing for balance disorders like an ECOG or a VEMP is also something that we provide here at St. Luke's. I always like to review a couple of hearing loss facts. I think some of them are surprising to some people. And again, it just kind of highlights how frequent we might be interacting with an individual that has some hearing loss. So 48 million Americans are diagnosed with some degree of hearing loss. 20% of Americans have tinnitus or ringing in their ears. And of those, 90% of those cases, that individual is most likely dealing with some hearing loss as well. So this is something I always highlight when talking to providers. If you have a patient that is complaining of ringing in their ears, it's always a good recommendation to have them get their hearing tested. Again, 90% of those individuals are going to have some degree of hearing loss. The other one I like to point out is the hearing loss by age. Most people think hearing loss is strictly, related to age. And as you can see, there is an age component to it. 50% of adults over the age of 75 do experience hearing loss. But the other 2, I think, are important as well. Individuals from 65 to 74, we're going to see a 24% likelihood of hearing loss, and then ages 41 to 59, 14%. So I will always tell patients and providers there's no right age to have a hearing test completed. If an individual is struggling or having problems, again, either with ringing in their ears, decreased speech understanding, we certainly want to get them tested to see what's going on. The global impact of hearing loss is around 20%, which is 1.5 billion people, which I think is a staggering number. And the way I like to look at that is the number of people that are suffering from hearing loss is more than individuals with Parkinson's, epilepsy, Alzheimer's, and diabetes combined. So I know we hear an awful lot about individuals with diabetes, Alzheimer's, and again, hearing loss is going to affect more than all of those combined. So again, it's very likely that we know someone with some hearing loss or working with a patient that has some hearing loss. So I do just want to kind of do a quick anatomy review about how we hear. So generally the ears are simply collecting the information and transporting that sound to the brain. The brain is then the important part. That's what's decoding the information once it's received. So hearing involves two interrelated processes and components of the auditory system. The first is the peripheral system, which again is going to be the pinna, your outer ear, and your middle ear. And again, that's what's essentially collecting the information and then transporting it to the central system. In order for the brain to decode, analyze that information, and make it make sense. There are also some non-auditory influences, such as cognitive processing, education, situational influences, and self-perception that go into an individual's ability to have a conversation and, fully participate. We need both of these systems, the peripheral system and the central system, to work in tandem for the person to be able to detect and understand the information and make it meaningful. Again, make it speech, make it music, so that that person can participate in all of the conversations that they would ordinarily. So again, just the anatomy of the ear. This kind of goes over the whole thing that we're evaluating. So I do want to make a quick stop here, and I like this image simply because there's a lot of information out there right now about patients being able to complete a hearing test via headphones or AirPods. So looking at this image, we do have our outer ear where we can get wax accumulation or debris, and then our middle ear where we can oftentimes have fluid or congestion buildup, especially in the Lehigh Valley with allergies. So we certainly want to make sure that an individual is not solely relying on getting a hearing test done through their AirPods or their computer speakers at home. One of the main reasons is we don't have someone there looking in the ear to make sure that the ear is healthy so that we can know for sure that we're getting adequate results to be able to make the most appropriate treatment plan and path moving forward. So that's just one kind of side note that keeps popping up often when I talk with providers and individuals about getting their hearing tested. But again, back to the anatomy of the ears. So as the sound travels from the peripheral system, the electrical signal that is created by the cochlea is sent to the auditory nerve, where it is then decoded by the brain. The central hearing system is dependent upon the integrity of that auditory signal as it passes from the peripheral system to that central system. So again, peripheral hearing is the ability to simply detect sound. Central hearing is the ability for the brain to understand and make sense of what it's receiving. So those environmental sounds, and again, that is requiring significantly higher level processing. This is where, again, the brain is going to take the information, make it make sense, ignore unwanted noise in restaurants, and be able to kind of create those complex signals to be able to make speech understandable so that they can comprehend and be a part of conversations. So when individuals come to see us, we're obviously going to do the hearing test, which really hasn't changed much. We're looking at the beeps that an individual can hear. This is going to provide us with your typical audiogram that you see here. We're looking at the degree, configuration, and type of hearing loss that each individual will have. These are very important for us to know so that we can make the best determination of what's going to be most beneficial for each individual patient. So again, the first part of our testing is going to be our pure tone testing. Simply what sounds can an individual hear? And then that's what's then plotted on our audiogram here. So what I've done is plotted a very typical hearing loss that we see related to age. So most individuals, as they get older, will start to see a decrease in their higher pitches. So again, over on the right-hand side of your graph, this is going to be those high-pitched sounds. And again, most individuals, as they age, will start to lose these first. And ordinarily, individuals in this same age group are going to have relatively normal low-pitched hearing, which again is where we're going to see volume. So low pitches equals volume, high pitches equals clarity. So in most cases, when you're discussing, talking with a patient, they're going to say that they don't understand what people are saying. They're often going to say, oh, well, my wife mumbles, my kids mumble when they talk to me. So they're hearing people, but not understanding it. And that's kind of a big part of the hearing test that you're going to get when you come see, the licensed audiologist here at St. Luke's. So it's important to know the beeps, but it's more important to understand the speech understanding, which I'm going to get into. But again, when we're looking at a hearing test like this with normal low-pitched hearing, an individual will be able to hear no problem. They're just really going to struggle to understand the information that they're getting. So to make that make a little bit more sense, I like using these two figures. So the one on the left-hand side simply goes over the audiogram as a whole. So again, from left to right, we're looking at low pitch, volume, high pitch, clarity. And then top to bottom is going to be volume. So up top, we have normal hearing all the way down to profound hearing. So the other graph or the other figure on the right-hand side, we often use with patients, and this helps explain some common sounds that you'll hear at home. But more importantly, it shows our speech banana. So this shows all of the different speech sounds and where they're located on this graph. So when looking at this individual again has normal low-pitched hearing. So they have access to all of these sounds. And again, no trouble hearing people talk. But as you can see, they very quickly drop to a very severe hearing loss, which means they do not have access to this information. So I always explain it to patients. If you're having a conversation and someone were to take a magic eraser and just kind of remove all of those sounds, your Fs, your S's, your THs, that's what that individual is hearing. So again, they're hearing some of the information, but not all of the information, which means they're needing to fill in all of these blanks and work very hard to understand the information that they're receiving. Now, this comes into play when we talk about speech understanding, which is the second part of the testing that we're going to do when an individual comes to see us. So again, we test those beeps, but again, more importantly, we test an individual's ability to understand speech and language. We want to know what is the brain capable of understanding once the information gets through the pathway, right? Once we make the information loud enough and the patient has access to it, does the brain still have the ability to understand all of those different speech sounds? So again, that's a very important part of our test. Some individuals will have the same exact hearing test, right? The same exact plotted points. We might have an individual with this hearing loss that has had it for a short amount of time, and they have beautiful speech understanding. Once we make the information loud enough, the brain still can detect, decode, and make sense of all of the information. But if we have an individual that has this hearing loss for an extended period of time, years and years, then what we often see is a decrease in speech understanding. And when that happens, we're starting to see that the areas of the brain designed for speech understanding are starting to lose their sensitivity, starting to lose their functionality to be able to understand all of those different sounds. So again, when we're talking about hearing loss or presbycusis, which is age-related hearing loss, we know that outer hair cells and other sensory cells of the cochlea are progressively getting damaged and are unable to regenerate. The results are then are causing an impaired encoding of sound, decreased precision, and distorted auditory signal that's being sent to the brain. Again, that individual is having to work much harder to simply understand the information. And again, I'll kind of get into why this is important in a second. So as an individual's functional performance, with their hearing depends not only on their peripheral hearing, but their central hearing ability. Again, that central auditory processing, being able to understand all the different speech sounds, specifically when it's not in a quiet, clear environment, right? We have speech and noise. We have demanding life environments that we're in and out of, different listening groups that we're with, group environments where it's much harder for an individual to process all of that information and make it meaningful and make it make sense. So I like this graphic because I think it kind of shows the overall effect that hearing loss can have. We know that it can affect, it can increase your risk of falls. We know that there's a link between cognitive decline and dementia, which is essentially what we're focusing on today. But again, hearing loss does have an impact, I think, overall on an individual's health. Reports and studies have showed that there is a 1.9 times greater risk of dementia among hearing impaired individuals 55 years of age and older compared to those with normal hearing. And studies have shown that an association between hearing loss and declines in global cognitive function, executive function, and processing speed and memory. So again, we know that there is some sort of link between hearing loss and global cognitive decline. So that's essentially what we're focusing on today. So the cognitive hearing science and that link between hearing loss, dementia, and cognitive decline. The general perception of people is that hearing loss is a relatively inconsequential part of aging. And unfortunately, we're realizing that it has a much more profound effect on the individual's overall health and, more importantly, their brain health. So there are three main hypotheses regarding the link or association between hearing loss and cognitive decline, and I want to talk about them today. So the three theories are the sensory deprivation theory, information degradation theory, and the common cause theory. So the sensory deprivation theory. So this is showing that prolonged sensory deprivation has an adverse effect on the brain, with possible changes to brain structure and brain function. So again, when we have hearing loss and we are depriving the brain of good quality auditory information, we start to see changes. We can start to see neural deafferentation, cortical reallocation of other cognitive processes, and atrophy in the speech processing regions of the brain. The resultant reorganization may add to existing brain pathology at the detriment of general cognitive performance by altering critical brain regions, which could otherwise be utilized for higher level cognitive processing, such as working memory. We can start to see reduced gray matter density and reductions in temporal lobe volume in individuals with hearing loss. And again, that prolonged sensory deprivation may lead to changes and decreases in cortical brain volume in conjunction with that seen with expected cognitive aging or neurodegenerative disease. So we've also seen that even in individuals that are considered free of dementia, no concerns with cognitive decline or dementia, but have hearing loss, we are seeing that there is a reduction in white matter microstructural integrity of the cortical regions critical for cognitive processing. So again, we are starting to see more and more that hearing loss alone is affecting the brain volume and the gray matter density of the area is important for speech and language understanding. So the sensory deprivation that we're experiencing with hearing loss may necessitate cortical reorganization, resulting in further restriction of cortical capacity available for general cognitive processing. So what does that all mean? So I like figures. My brain makes sense of figures, not words. So I like this picture because I think it plainly shows kind of what that was all saying. So the sensory deprivation theory, or most call it the use it or lose it theory, is suggesting that cognitive impairment due to hearing loss is happening in one of two ways. So the first way, which would be this gray pathway, is stating that due to long-term auditory deprivation, resulting from hearing loss, the areas of the brain designed specifically, the auditory cortex, start to lose functionality. This is suggesting that there are changes occurring to the gray matter of the brain, causing a decrease in neural activity available to perform cognitive tasks. So this reallocation or lack of resources is affecting the brain's integrity and overall function, thusly affecting an individual's cognitive ability. So again, as we see, and as I kind of mentioned previously when discussing the audiogram, when we have an individual that's not stimulating the auditory pathway consistently, we start to see that the areas of the brain for speech and language start to lose functionality. And over time, when an area of the brain is not working, it's going to start to atrophy. I always tell my patients, think of your brain like a muscle. If we don't work out all of our muscle groups, we start to see one of them getting weaker. It's not building, it's not staying strong. And you have to think of your brain in the same way. So even when we have some hearing loss, those areas of the auditory cortex are not being stimulated. And over time, we start to see changes. The second way, which would be the one down here, is suggesting that with communication breakdowns, which we tend to see often with individuals with hearing loss, we'll see a reduction in their social interactions, which can lead to social isolation or withdrawal from activities, which can then lead to depression, which we know has been shown to affect cognitive function as well. So research has indicated that even when a patient perceives that they are socially isolated, it is a risk for poor overall cognitive performance. We see faster cognitive decline. And so we can generally assume that these impairments related to hearing loss can cascade either directly or indirectly, leading to cognitive impairment. So the second part of this is just showing how hearing aids could potentially alleviate these concerns, right? So if we follow the first pathway, so we have hearing loss, but we implement with hearing aids. So we no longer have degraded auditory input going through the system. So the neural activity of that pathway stays strong and active. So we would see less changes to the brain, again, because that auditory cortex is being stimulated wholly. And then again, reduce the possibility of brain volume atrophy and cognitive impairment. And then the same for here. So again, hearing loss, implementing with hearing aids. Hopefully we reduce the number of times that there's any communication breakdown. So we would decrease the likelihood that this individual is isolating themselves and decrease the likelihood of depression. And then again, therefore, decreasing the likelihood of any sort of cognitive decline. That in general is the sensory deprivation or the use it or lose it theory. The second one is the information degradation theory. So while the sensory deprivation hypothesis suggests physical changes to the brain due to prolonged hearing loss, which subsequently impacts cognitive processing, the information degradation theory proposes the association stems from increased demands on cognitive processing in order to compensate for the degraded auditory information. So additional processing that's required to compensate for degraded auditory perception draws on the same resources that are needed for other higher level cognitive processing or semantic encoding. This increased cognitive demand required to appropriately encode, decode the auditory stimulus that the brain is receiving requires extensive listening effort, particularly with memory, attention, and executive function. So an individual with hearing loss, this increased cognitive demand and increased listening effort may increase the overall cognitive load needed at any time of day as the auditory system never turns off, which would then draw on the other cognitive resources available and their ability to compensate for cognitive changes and resulting in an earlier presentation of dementia symptoms. So I always tell my patients, this comes up a lot when we fit with hearing aids. Patients will often ask, do I need to wear the hearing aids all the time? And the answer is yes, because as I just stated, the auditory system never shuts off, right? We're constantly analyzing what's going on in our environment. Even if you're home reading a book, there are sounds in your environment that the brain is constantly analyzing, decoding, and cataloging, determining whether, that noise that you just heard is something that you need to get up and respond to, or if it's something that you can ignore. So that system's never turning off. And since it's never turning off, we would consistently be borrowing cognitive resources to make sure we're aware of the things that are going on around us, or to understand speech when we're having a conversation. So with these compensatory strategies, we often see individuals becoming fatigued when trying to complete multiple tasks that require both listening and understanding. And this is kind of referring to effortful listening. And I'm sure you've talked with somebody that kind of leans forward, maybe even cups their ear, has a little like squinty face on because they are really trying to understand what you're saying, right? That auditory signal is degraded. It's not clear. So they're working so much harder to fill in all of those little blanks to make what you're saying make sense. And again, I think this picture also very plainly shows what I just described. So again, the cognitive load is the cognitive effort or amount of information processing required by an individual to perform a task. The basic idea is that if the task requires too much cognitive ability, the completion of that task will be hindered due to the limited cognitive capacity in working memory. So when we look at this figure in a healthy hearing individual, we have X number of cognitive resources. And when we don't have the burden of hearing loss, we can allocate these cognitive resources evenly, appropriately for each of those tasks. When talking about people with hearing loss, that cognitive load comes into play with listening effort. Again, that leaning forward, cupping your ears, squinty face, that listening effort refers to the amount of concentration and attention just to simply understand speech. So when a person has hearing loss, auditory signals are degraded, which then requires much more cognitive resources to simply understand and make sense of what you're saying, which then in turn causes a diversion of other cognitive tasks, resulting in a cognitive reserve depletion. So that's reviewing the second part of this figure. So again, we have the same number of cognitive resources, but now we're adding the weight and burden of hearing loss. So again, every time this individual is having a conversation, they have to work much, much harder to make sense of all of the information that they're receiving. And when we're doing that, we're constantly borrowing cognitive resources from other cognitive tasks. And when that happens long term on a daily basis, we'll start to see structural changes of the brain, and neurodegeneration can occur, which can affect other cognitive processes. So, thus, starting this cycle where cognitive resources available to perform tasks are limited or reduced. So, with regards to hearing impaired people, resources being diverted to auditory processing are then taking away cognitive resources from other cognitive processes, such as working memory. And then again, this is what can potentially lead to that further increased cognitive decline. So I don't have a nice little follow-up picture to this to show what hearing aids would do, but essentially, if we implemented hearing aids, we would release some of that burden. We would be able to keep some of these cognitive tasks where they belong and reduce the number of times that we're diverting those cognitive resources simply to auditory processing. The last one is the common cause theory. So this is reviewing a potential common mechanism that might include the overall neural degeneration common with aging, resulting in both decreased auditory ability and decreased cognitive performance. So this is essentially referring to, I kind of use did the chicken or the egg come first? So dementia pathology from a central cause may therefore produce early dysfunction within the auditory system, resulting in impaired hearing ability prior to the presentation of more general cognitive decline impairments, right? So the question is, was the AD pathology always there, underlying the initial presentation of impaired hearing ability? So again, which one came first? Are we going to see an individual with cognitive decline presenting with hearing loss prior to them presenting with cognitive decline? It's also possible that degraded peripheral signals from the hearing impairment are leading to dysfunctional pattern processing within the central auditory system and interacting with existing neurodegenerative pathology, resulting in that observed dissociation. So in this sense, it's asking, is the underlying hearing impairment interacting with the existing AD pathology, resulting in poorer overall task completion and slower processing? We know as we age, decreased processing speed, slower cognitive functioning, slower processing speed for sensory integration and perception are going to again be decreased. This one is essentially suggesting, is one causing the other, or are they kind of coexisting and unfortunately working against one another? So this figure I really liked because, again, it's kind of showing the overall changes to the brain structure that we often see when associated with hearing loss all on its own. So you can see that in a normal hearing individual, the overall brain volume is larger and the neural activity is higher compared to that individual with hearing loss. So the common cause hypothesis, again, there are two sides. Whether the increased neural activity from the degraded auditory input is causing or increasing the AD pathology, or is the degraded auditory input from hearing loss reducing activity for auditory cognitive processes within the medial temporal lobe? And again, this is what remains unclear. However, either speculation supports early identification of hearing loss prior to prolonged duration of decreased auditory input and broad hearing dementia intervention strategies. So just kind of an overview of the three main theories. So again, we have the sensory deprivation theory, the use it or lose it theory. So prolonged sensory deprivation, we start to see changes to the structure of the brain, the function of the auditory cortex, being able to understand certain speech sounds, and the overall, eventual reduction in gray matter and density of the brain. The information degradation theory is that effortful listening where we're constantly borrowing cognitive resources simply to have a conversation and understand what the information is being said. By continuing to borrow these cognitive resources, we will eventually start to see neurodegeneration and reallocation of those cognitive tasks, again, removing them from those other higher level cognitive functions like working memory. And then again, the common cause. So this assumes the existence of a common factor that is responsible for age-related deterioration in cognitive and non-cognitive processes and proposes that age-related declines are shared across multiple and seemingly incongruent functions. So this is another figure that I liked. I think this helps show how all of these mechanisms and concerns are kind of interconnected. And it also brings up the social aspect of each individual, and it's linked to depression and cognitive impairment. So when verbal communication fails for an individual with hearing loss, which we see happen very often, this can severely reduce an individual's social interactions. Reduced socialization is known to occur along with loneliness, apathy, and depression. We know that research has shown that even a perceived risk of social isolation is a factor for faster cognitive decline, poor executive functioning, increased negativity, and overall poorer cognitive performance. So again, this is suggesting that social isolation and depression as a result of hearing loss may indirectly or directly lead to cognitive impairment. So again, that link between social isolation and hearing loss. So other risk factors for dementia may also mediate the association of hearing and cognition, including loneliness, social isolation, depression, decreased physical activity, or frailty. Studies have demonstrated the presence of hearing loss leads to increased social isolation and or loneliness for some older adults, as individuals with hearing loss may withdraw from previously enjoyed activities or social interactions due to the inability to engage and communicate with others. And this always makes me think of, I feel like everyone always has that one patient, and I'm going to talk about this one patient. His name's John, and unfortunately he's no longer with us, but I started working with him when I first started here at St. Luke's 9 years ago. But when he came in, he was miserable. He sat slumped in the chair, arms crossed, barely made eye contact. And for most of the appointment, I spoke with his wife about the concerns he was having and the issues that he was dealing with. He agreed to try hearing aids. And as I was fitting them and programming them, it was like a light switch went off. He sat up straight. He started interacting. By the end of the appointment, he actually cracked a joke. And it was just a really profound experience, right? Like I say it in these presentations, I say it to providers, but seeing it in real life, it's always that one patient I tell students about. And from that moment forward, after I fit him and he would come in, and his wife would say, he's back to who he used to be, chatting with everyone, cracking jokes, but prior to that, though his wife would say that he doesn't go anywhere. He doesn't want to leave the house. He doesn't want to be a burden to friends and family because those individuals with hearing loss constantly have to ask what and have people repeat themselves. And they don't want to consistently do that. And then they oftentimes are at a group conversation, but are on the outside of it, right? They didn't get the joke that everyone's laughing at because they missed the punchline. And rather than asking for someone to repeat themselves, they just sit there, maybe laugh along with everyone, but they're not really part of that group. And when that happens repeatedly, individuals will just start to isolate themselves. They don't want to go to poker night or bridge club or to their grandkids' graduation because, again, they feel like a burden. And then that's where we start to see that link between social isolation and loneliness and that increased risk of depression. We also know that hearing loss can lead to reduced physical activity and physical functioning, which are also both risks for dementia due to the decreased auditory awareness with surroundings and with their surroundings and anxiety. So again, that social isolation is, I think, personally, a very huge part of hearing loss and an individual's overall health and sense of well-being and quality of life. So now what, right? So how do we treat, what do we do from here? So researchers have actually found that elderly adults with hearing loss that have been treated with hearing aids had similar rates of cognitive decline compared to adults with normal hearing sensitivity. So that's suggesting that hearing aids, when used, may attenuate cognitive decline that is otherwise accelerated by hearing loss. One of the other interesting things that I actually just recently found was that in addition to potentially serving as a dementia prevention strategy, hearing aids may present an opportunity for intervention for neuropsychiatric symptoms, or NPS, at all stages of dementia and negative health outcomes associated with NPS. So we often see this with breakdowns in communication with individuals with dementia or cognitive impairment and their caregivers, along with the decreased awareness of their surroundings, which can potentially contribute to behavioral changes, right? We often see these individuals with more progressed disease are agitated, they're nervous, they're confused. And again, part of that might be that they just have a decreased awareness of what's going on around them, their environment, or what their caregiver is trying to communicate to them. So the use of hearing aids in older adults with cognitive impairment has been found to result in fewer and less severe NPSs and less severe depressive symptoms. Therefore, hearing aids used among dementia patients demonstrate improved communication, reduced NPS, decreased perception of hearing handicap, and improved overall quality of life for both the patient and the caregiver. And then lastly, so again, it's been reported that by maintaining strong social connections, one can prevent cognitive decline and prolong the onset of dementia. So again, if we know that individuals are going to potentially self-isolate themselves due to hearing loss and that communication breakdown, could we not then say that by wearing hearing aids and potentially reducing the number of times that this individual feels that they are isolated, we might be able to continue to build strong social connections and then thereby reduce the potential risk for cognitive decline? So that brings us to hearing aids. Again, St. Luke's audiologists, we provide hearing aids. We troubleshoot, fit, dispense hearing aids of all shapes and sizes. They come in all price ranges. They are Bluetooth compatible. They are rechargeable. So now individuals are like their younger counterparts. And instead of wearing AirPods, they can wear their hearing aids and stream podcasts and audiobooks. They can go to the gym and put on noise canceling and listen to music. So hearing aids truly are phenomenal devices. I will tell everyone, though, they are not corrective, right? They are not glasses. Their goal is to collect more data so that the brain has more information to decode and interpret. What the brain does with that information, the hearing aid has no control over. So this is where it becomes important that we take a proactive approach to hearing loss and your overall hearing health care. Because again, if we wait too long and we start to see those changes to the auditory cortex and its inability to understand certain speech sounds, by implementing a hearing aid, we cannot correct that. So it will always be an uphill battle for that patient. And this is oftentimes a very hard thing for individuals to come to the realization and accept that. So again, we always want to promote proactive care about their hearing health. And again, using hearing aids as management, we can support cognition through indirect pathways like improving social engagement, but also potentially decreasing the cognitive load and strain on the central auditory function, and then potentially decrease the likelihood of cognitive decline. So sadly, only on average, 30% of eligible adults obtain hearing aids in the US. It typically takes individuals 4 years after they are diagnosed with a hearing loss before they make any sort of decision to pursue hearing aids. So again, that's that proactive approach. We want to do something sooner rather than later. So management of hearing loss through hearing aids may not only decrease the risk of neuropsychiatric conditions, but may also improve treatment adherence, patient satisfaction, overall health, and quality of life. So in general, the key takeaways from today's presentation is that there, again, is a reported risk of 1.9 times greater incidence of dementia among hearing impaired individuals 55 years and older compared to those with normal hearing. Research has shown that delaying the onset of dementia by just 5 years through intervention could lead to a 57% reduction in the number of dementia cases seen and a 40% lower cost of care and service in 30 years. Additionally, it's reported that, again, researchers showing that hearing aids may attenuate cognitive decline. So hearing aids have been shown to positively affect episodic memory scores and have shown that the decline in episodic memory scores was slower after the use of hearing aids. Although episodic memory declined with age, this rate of decline was significantly less after the start of hearing aids and may affect a person's overall feeling of self-worth and reduced social isolation. So again, that's my patient, John, who didn't want to go anywhere or see anybody. We started to see him turn around after we implemented hearing aids. So just some food for thought. This was something I came across that I thought was very interesting. So it's estimated that by 2050, nearly 2.5 billion people will have hearing loss. That is 1 in 4 people. And by 2060, nearly 73 million in the US alone will be diagnosed with hearing loss. However, recent studies are showing that the overall prevalence of hearing loss is increasing due to the number of older adults. However, the age-specific prevalence of hearing loss in the US appears to be decreasing by about 2% over the last decade compared to adults in the prior decade. So why is this happening? So the thought is that we are starting to see this improvement in healthcare, access to care, and prevention of known risk factors like noise-induced hearing loss. So now most companies that have high levels of noise in the occupation have hearing conservation plans in place where the individuals are provided with hearing protection, annual hearing tests, and again, more education on the concerns for hearing loss and the need for proactive approaches to treating hearing loss and or wearing hearing protection whenever possible. We're also seeing better management of vascular diseases and diabetes, which again are both risk factors for increased hearing loss. So I liked this because I figured what we're doing today is kind of on point, right? We're trying to increase the awareness and education, not only with providers, but with our patients. So anytime we start to see or work with an individual or have a family member that's really struggling, we want to think about that proactive approach so that we can help this individual sooner rather than later. So again, that we don't have to deal with those adverse effects of untreated hearing loss. So this is where you guys come in. So making that referral. So I always like to play both sides, right? So if hearing aids truly aren't doing anything for better cognition, but rather they're just helping improve social interaction and social engagement, again, we can potentially see an increase a decrease in that potential cognitive decline. Additionally, where you guys can come in is when we're working with cognitively abled individuals or well-educated individuals, they're aware of specialists like audiologists and their need for some sort of treatment like hearing aids. But when we're working with less cognitively able individuals or less educated individuals, then it becomes the responsibility of their healthcare professionals to make the referral and make the individual aware that they do need to seek a specialist help and potentially seek some sort of treatment option like hearing aids. So then again, that's where that responsibility of making the referral whenever working with a patient that's either complaining of ringing in their ears, decreased speech understanding, the TV is getting louder, my wife mumbles. Those are all clear indications that this individual might be struggling with some hearing loss and would benefit from having a real diagnostic hearing test provided by the licensed audiologist here at St. Luke's. So again, that just brings me back to that multidisciplinary approach where all pieces of a patient's puzzle working together is going to certainly provide better outcomes and better quality of life for our patients. Thank you. Any questions? Do people ask questions?
Yes.
Okay.
So if you have any questions, please feel free to unmute yourself and ask, or type into the chat. Waiting for them to do that. One question I have for you. There tends to be a stigma about wearing hearing aids, especially at a younger age.
Sure.
How do you address that issue with people who are younger and who may or may have a hearing difficulty but don't want to address that issue because of the stigma?
Sure, it's a fantastic question, and it happens all the time. So the hearing aids nowadays, and unfortunately I don't have any with me. I kind of feel like I should have brought one, but they're very discreet. So most cases you're not even going to notice it. There's a part that goes behind the ear, similar to like the arm of your glasses. And then there's a very small wire that runs down the skin, and then a little earbud that tucks into the ear. So from the front and even from the side, you're really not going to notice much because again, that just kind of tucks in. The only time that you would potentially see it is if you're standing directly behind the person, where you could see the part that goes back here. Now, hearing aids come in a variety of colors that will either match skin tone or hair tone. I've also had patients that match the arm of their glasses. So again, when they're sitting back there, it just looks like it's part of your glasses. But the other thing I think that's kind of cool nowadays is that there's less of a stigma about something being on your ear, right? Everyone has AirPods in their ear or some sort of Bluetooth device that's hooked over the back or going into the ear. So I think overall that stigma is starting to be reduced. And generally speaking, the hearing aids that we dispense are smaller than all of those devices that you're going to see as far as Bluetooth, AirPods, anything like that. But as far as that goes, I mean, the best we can do is make it as small as possible and match the color as well as we can.
Thank you.
Mm-hmm.
The other question, if somebody's listening to this in California and obviously not near Pennsylvania, how would they find an audiologist versus, going to Costco?
Sure. So generally, I would look into healthcare systems or your private practices. So most ENT clinics have an audiologist that's in employment. So you'd be able to get your testing done through an ear, nose, and throat facility as well. But there are a lot of things online. If you go to any of the major hearing aid manufacturers like Oticon or Phonak, you can actually look through their websites and find audiologists in the area that are able to help people.
Thank you.
Mm-hmm.
What other questions do you guys have? So if you do have other questions that do come up, please feel free to reach out to either me or to Dr. Hilderbrandt. And then make sure that when you, as soon as we sign off, make sure you complete your course evaluation and also your course quiz to get your CE or CME credit. And if you didn't sign in, please make sure you do using the sign-in code or QR code that's in the chat. And if you're watching the recorded version, then you're already in. So thank you very much.
Thank you.
And have a great rest of your day.